Sweet. All right, so here's everything we've done to this point. Body starts in homeostasis, happy, healthy creature, happy, healthy tissue. We add some kind of insult. If it is sub-lethal, as in not big enough to kill the cell, our cells will degenerate, but this is reversible. We can come back from this if we remove the insult, and we can recover. If we don't remove the insult, we progress to necrosis, which is irreversible. But there's more we can do. We don't only have to die, we can also adapt to changes. So depending on the insult, your cells may be able to adapt to the stimulus. Adaptations are reversible. If you remove the stimulus, you can go back to homeostasis. So you can recover. These are parallel tracks to degeneration. However, at any point while you're adapting, if it gets too much for you, you can switch to this pathway. You can degenerate and or die or recover, right? So this is like a choose your own adventure for the cell. If the insult persists, we will move on to irreversible change. Many adaptations, while adaptive in the short term, if they become progressive and severe, they can progress to tumors, cancer, which is then irreversible. Okay, so parallel pathways, degeneration reversible, we can recover or die. Adaptation reversible, we can recover or we can turn it into something bad. All right, so adaptations. Again, what happens to the cell is dependent very much on the insult. How severe is it? What is it? How prolonged is it? Cell can degenerate, cell can die, or it can adapt. Here, the cell is basically trying to create its own new normal. It's trying to reach a new homeostasis under the current conditions. So, considerations. Things that cause adaptation preferentially over degeneration, necrosis. They have to be sublethal, so it has to be a pretty mild insult that's not enough to outright kill the cell. But they're often more long-term. So adaptations take a little more time. You're talking about timeline of degeneration, necrosis, apoptosis. I'm not sure, but all pretty acute. These are all a little bit more prolonged. So the cell needs to have time to be able to implement these adaptations. How you can adapt what you're capable of depends on your cell type. So are you a cell that's able to divide or not? Are you a cell that prefers to divide? Like you're talking about your skin cells is one that is always dividing, rapidly dividing. That's going to respond differently than a muscle cell, which doesn't really have significant division capability, right? And then remember that adaptation, like degeneration, has its limits. There's going to be a point of no return where we're not coming back and we're into irreversible changes, either degeneration, death, or hypoplasia. Here is our delicious menu of cellular adaptations. We're going to start with autophagy, just for you. Okay. I don't care how many times I see this photo. His eyes, it's the eyes, and then the elimination. Okay, so auto is self-phage is eating. This is the cell literally eating itself. It's also called autophagocytosis. This is how our cell recycles our damaged parts. So it's how we remove old or damaged organelles. We break them down into their components, and then we use those components to build fresh, new, shiny organelles. So that's physiologic, just normal turnover in the cell. If we have a chronic low-level sublethal injury, again, not enough to kill the cell, but enough to cause it to start paring down its luxury functions. So for example, nutrient starvation. The cell is going to attempt to survive by, again, kind of triaging. It's going to reduce those luxury functions and recycle the parts that are being used for those things into surviving functions. So rather than using ATP to spin my little cilia whirligig as I'm dying, I'm going to save that ATP. I might actually break down the cilia and use those proteins for something more important to my survival. The end result of autophagy is lipofuscin, where we talked about that last week. It's that brown, I think I said poop a lot. It's cellular poop. It's these brown granules that accumulate in the cell because they're this indigestible end product of this kind of metabolism. So they build up with age, they're not really important to the cell, they're just kind of putting them in the closet, like this is my dirt, my poo closet. So can be physiologic, also has a pretty strong role in disease. It's very prominent during atrophy, which is a change we're going to talk about next. Autophagy can either promote or prevent neoplasia. I'm not going to say a lot about that because I asked you a discussion question on how that is. So I would like you guys to think about maybe how that might work. Neurodegenerative disease, Alzheimer's, Huntington's, these are both disorders of dysregulated autophagy. So there's some protein that the cell should be able to break down that it can't, and it's building up. That's Alzheimer's. Lots of infectious diseases. Autophagy has a role in antigen presentation for these cells that have intracellular infections. I need to be able to digest my own parts because that infectious organism is now a part of my cell, and I need to present it. So it's part of antigen presentation. Strong parallels to phagocytosis. The name is the same, it's autophagocytosis, so eating yourself. Instead of nomming on something from the outside, we are noshing on our inside parts. So instead of making a phagosome that goes out and chomps the the environment, it's forming inside the cell and encircling things that we want to degrade. These things then fuse with a lysosome, bag of digestive enzymes. You get digestion. Alzheimer's, disease of disordered autophagy. How we end up with these misfolded tangles of proteins that should be able to be broken down by the cell. They are not. Okay, atrophy. It said that autophagy is prominent during atrophy. Atrophy is another adaptive process. A means none or no or nothing. Trophic means growth. So this is a decrease in cell size and or number after you've reached normal growth. So this is an adult person, hope we can appreciate that. You can imagine his legs did not always look like this. At some point he had normal musculature. Something has happened to this person. They now have either, they've lost the nerve supply to these muscles, they are not able to walk, and so they've atrophied from disuse. But these muscles reach normal size, and then for some reason, probably due to disease, they shrunk, they atrophied. All the cells are smaller, so the tissue is smaller. Again, this can be physiologic or pathologic. This is how we involute our thymus. Involution is the word for physiologic atrophy. Your mammary gland, after you withdraw hormones, involutes. Your thymus over age involutes. Can also be pathologic. So again, think about these sad little stick legs. Can be disuse, maybe they're not walking, maybe they have a nerve problem where the muscles are not innervated, maybe they're starving. This could be a person with cachexia, which is whole body starvation. We see it with tumors, we see it with some severe infectious diseases, but there's something going on. Maybe he has a hormonal imbalance, maybe he has pressure. That doesn't really apply here, but when you have a mass in an organ and it's causing pressure on a tissue, that pressure can cause the tissue to atrophy. Whatever the cause, the result is a decrease in organ and tissue size, very importantly, after normal growth has been attained. This is an acquired lesion. Do you guys know what I mean when I say acquired? So there's things that are congenital, which means you were born with them. And there are things that are acquired, which means you picked up along the way. So this is something you pick up along the way. Atrophy cannot be congenital because by definition, it has to start normal size. Normal adult growth. All of these changes that we're talking about are theoretically reversible if the cause is removed. Atrophy is often in real life not reversible because of the causes. These causes are usually very prolonged sublethal insult. There's something that's been going on for a long time. So they often do end up resulting in permanent defects in the organ. Theoretically, it is technically reversible, but in application, once atrophy is there, it's usually there for the ride. There's usually a permanent deficit in the organ. Again, involution, the definition is physiologic atrophy. So this is just showing in the human thymus, how your organ decreases with age. And here's histology showing a neonatal or a young animal thymus. And then over time, that epithelial and lymphoid tissue atrophies over time. You have smaller cells and fewer cells, and then you replace a lot of the tissue with that. Questions on atrophy or autophagy? Did I answer your autophagy question?
My question was, so it's cellular recycling, does it result in cell death, like it will eventually completely eat itself, or will it then switch to apoptosis?
It'll switch to apoptosis. So, yeah. You cannot eat yourself to death. I challenge you to try. Yeah.
So you were saying, so atrophy that I'm familiar with is the perfect future of what I'm talking about, the wasting essentially. But you're saying that atrophy can happen to any organ anywhere.
It can happen anywhere, anytime.
And that just basically shows up as like a shrunken liver or something like that.
It depends where you are. I show a lot of ways. I have some photos, if you will. And again, remember that we're going to build on this stuff. So these processes are going to show up every week from now on in all the other disease stuff we talk about, right? All right, so atrophic rhinitis. Here's another great example. When I think of atrophy, the disease is, or the thing is literally in the name of the disease. Everybody heard of this yet? Anybody seen it in real life? The pigs with the right? They look like you ran into a door. So this is a really important disease of pigs. It's a bacterial infection with two different pathogens. One secretes a toxin that stimulates osteoblasts to start resorbing the bone of your turbinates. So over here we have normal turbinates. They look like little butterflies, rolls. Over here we have progressive loss of both turbinate bone and mucosa. You think about the surface area in here is being reduced over time until we have basically nothing. This guy has nubs for turbinates. Severe diffuse turbinate atrophy. Here. Also deformation of the face. The septum right here is deviated to the whatever side that is. Whatever side. This is really important to the animal, not just because it makes them really ugly, but because this predisposes to lower respiratory tract infection. The job of the turbinates is to filter stuff out before it gets to your lungs. So loss of function also accompanies atrophy. Here's another really common example. We see this in animals that have severe wasting. So again, I use the term cachexia, C-A. Oh, it's spelled it in the, you don't have to spell it. Cachexia, that's how you spell it. So we see it in cases of starvation, malnutrition, severe chronic disease where you are in chronic negative energy balance or starving. What's happening is you need your fat because you're not getting whatever nutrients you need. So you suck all the nutrition out of your fat until it's literally sucked dry. This is what sucked dry fat looks like. It looks like clear gelatin. Anybody eat bone marrow? What do I get hungry in here? Does this look like normal, like something you would want to eat? No, it doesn't mean either. Normal, healthy bone marrow, especially in young animals, should be like red, kind of meaty looking. With age, it gets more fat in it, but it should look like delicious edible fat, not like jelly gross fat. The best place to see this is in the bone marrow and at the base of the heart. Here I've chopped open a bone, got a section of bone marrow. Bone marrow should never ever be see-through. That is highly abnormal. Here's what that looks like on histology. So normal, healthy, happy adipocytes are mostly fat. They have a tiny little peripheral nucleus. These are atrophic adipocytes. See these, the actual lipid component of the cell is much smaller. I can actually see cytoplasm. This blue is the cytoplasm of adipocytes. You usually can't see it because it is full of lipid. Here we can actually see it because there's no fat left.
Physiologically, what would this do to the animal's health or whoever is having this?
Physiologically, this doesn't matter to the animal because whatever else is going on is about to kill it. It is starving to death from whatever the primary disease process is. So I see this a lot in neonates that have like chronic diarrhea / pneumonia. I see it in older small ruminants with dental disease, so they stop eating. I see this a lot in camelids because they're so fluffy that it's hard to appreciate that they're losing weight unless you actually touch them. So this is really common. Basically, many disease processes cause this, but it's severe underlying disease and like essential like starvation of the body is what's happening.
Two quick questions. When you say best place to visualize in these two places, is that grossly?
Yes,
Okay,
but it'll be everywhere. Everywhere there's fat.
got it. And we talk about brown fat versus red.
Sure. What do you want to talk about?
Well, is it specific to
I'm talking about white fat.
what?
Brown fat in animals is hard to see unless you're dealing with a rodent or a baby thing.
But it doesn't, if we're talking about serous atrophy of fat, it doesn't care if it's brown.
I don't know that brown fat undergoes serous atrophy because it's like, it's a different beast. Brown fat is its own thing.
So when you talk about like starvation or malnutrition.
Yep.
Is that something that you can bring back, or we're talking about to the point of no?
It depends on the cause,
Okay,
right? So you could force feed an animal, but if an animal has Johne's disease and it's not able to absorb nutrients, your force feeding is not gonna help it, right?
so then,
If the animal has a tumor and it's in a catabolic state because of the pro-inflammatory state in its tumor, unless you get rid of that tumor, it's not gonna help. So it depends on the underlying disease, right? Which is what you're trying to treat. This is just a sign of an underlying disease. This is not the disease in itself. The importance of this to me as a pathologist, when I see this on necropsy, I say this animal has been in negative energy balance for a long time. And then I go looking for the cause. Does it have GI parasites? Does it have dental disease? Does it have a tumor somewhere? Here's what that looks like on the heart. So over here, normal, happy, healthy heart with lots of pericardial fat right at the base. The fat is still here, but it's clear and gelatinous and sad and atrophic. Atrophy, shrinking, smallening, saddening. Okay, I hammered that atrophy is a reduction in tissue size after normal size has been attained. That's to differentiate it from this guy, which is very similar. Hypo is less or under, plasia is growth. There's plastic growth and trophic growth. So hypoplasia means less growth. Hypoplasia is a birth defect in which the organ or tissue is too small. It never attained normal adult size. Versus atrophy was adult size, shrunk. Hypoplasia, never adult size. So one's a birth defect that is not reversible. One is an adaptation that is reversible, but they can look the same. So it can be really hard to distinguish those two without some kind of additional information. What else is going on in the body? Do I have a signalment? Is this a young animal? It's probably more likely to have a congenital lesion. Is it an older animal? It's probably more likely to be atrophy. What's the history? What's the histology look like? Do I have other signs of developmental defects? Is this kidney, when I look at it under the microscope, is it dysplastic? Dys means abnormal, plastic is growth. Is there weird growth patterns in there that might tell me that this kidney was not ever normal to begin with? Or do I see things like scar tissue, evidence of previous inflammation, disease that would cause atrophy? Okay. So in these two cases, what do we think? These cat brains, do we think this is atrophy or hypoplasia? Votes for hypoplasia? Votes for atrophy? I agree. Why? Because brain. You think the brain can't atrophy? Brain can definitely atrophy.
you agree with which one?
What?
If you said I agree, which one do you agree with?
I agree that this is hypoplasia.
Because cerebellar hypoplasia is something we've learned about.
Because cerebellar hypoplasia is a known disease in this species. Do you know what causes it?
Oh, it's a virus. It's
And leukopenia. Parvoviruses do this. What? BBDV also, yes, not a cat. Okay, yes, this is hypoplasia. What about the kidney? Hypoplasia. Atrophy. No clue. I'm putting my hand up for no clue. I need to know more about this animal. I suspect, based on many years of experience, that it is hypoplastic, because when I look at it, it looks like a normal kidney, just smaller. It doesn't look like there's been disease causing it to shrink or become weird. It looks exactly like a normal kidney, just teeny tiny. It's like a little peanut kidney.
I thought cat kidneys are the only ones that have them.
That is a cat. Oops.
Okay.
You caught me. That's a cat kidney. You can tell from the vessels. Oopsie.
Are there certain tissues or organs that you see one more than the other with, like Brian was talking about, hypoplasia because of anemia?
Difficult question. I'm not gonna answer it because I want you to believe that these are available choices in every organ, because they are. There probably is some difference in incidence, but I don't really want to think about it right now. It's not important. That's like an advanced pathology question. Finish vet school, come to a residence with me in like year 2. We'll get to that. Okay. Great question. Put it on a calendar. So these two can be hard to tell apart, but it's an important distinction. Because one means there is disease there that's been ongoing and chronic, and one means you have probably a genetic or some kind of birth defect.
Sarah Keller, hypoplasia with him, meaning we also see like Thomas about, it's like, is it just quick cerebellum, or is it all, is like there's a gap between the arms that they're waiting for? So
There's a gap because the cerebellum is smaller and it usually fills that space. It really only hits the cerebellum, and it's for developmental reasons. Your brain is mostly developed once you exit it. Your cerebellum continues to develop after you exit the womb, so it's a little delayed, so there's like some plastic change. That's why the cerebellum is a target for hypoplasia with viruses. Yeah. Can you all show please? Thank you.
Autophagy, right, has a role in atrophy. Are we gonna get there, or?
Oh, didn't we already do it?
Did we?
Yeah, the cell moves from synthesizing, so it goes from making things to degrading things.
Okay.
So we're breaking down cell parts because we're in survival mode.
And then is that common to like all atrophy, or?
Yes, that is a characteristic of atrophy, increase in autophagocytosis.
I have a question on the next slide, the chart about the blindness. I was just thinking about that sheet precedent we saw with the sign lollipop. And I'm wondering, in animal years.
Yeah.
This is like a human chart.
It definitely is.
Okay. Is there a percentage of age then tied to the age fully reduced, or 10% or less than age? Like,
It's probably species dependent.
okay.
I don't have those numbers available to me.
Or you can kind of really max age.
Are you relating that to the thymoma?
Well, yeah, because that was an older.
Yep.
Animal.
Yep. So the old animal, the old human still has thymic tissue in there. It's just very small. But there is still a population of cells in there that can become aplastic. Separate issue. Really good question. More? Yeah.
The picture of the 2 hearts on the slide about the serous atrophy, are they different sizes for other reasons?
They're probably different sized animals. This one's probably younger or a smaller breed or something. Okay, that's my cue.
Adipose cells right there.
Are there what?
On the left part, there's still adipose cells present, they're just.
Yes, so the same number of cells is present. This is not a reduction in the number of fat cells. We still have lots of fat cells here, they're all just smaller, so the whole tissue shrinks. So this animal has the same number of cells, but every cell is smaller and see-through.